Hello and welcome to Shared Medical Appointments, Part 1, Value and Return on Investment. You may have heard about shared medical appointments but haven't given it much thought because you don't know the benefits for you and your patients and want to know if the extra effort will truly be worth it. You also may be wondering how to operationalize shared medical appointments once you decide it is worth the effort. Operationalizing SMAs is covered in Part 2 of this two-part series. Welcome again. My name is Karen Tenkate from the Quality Innovation Network National Coordinating Center, and I will be your facilitator. The two objectives for this bite-sized learning are for physicians to see the value of investing in shared medical appointments for themselves and their patients, and that physicians will see the major components of a shared medical appointment and how those components could be billed. Today's topics: benefits to the patient, benefits to the provider, quality versus cost, types of conditions for which shared medical appointments would be appropriate, and mainly we will look at return on investment from a quality, efficiency, and billing perspective. Today I have two experts, Dr. Robert Schreiber and Dr. David A. Guggenheim, who will explain these topics in detail in the minutes that we have. Dr. Robert Schreiber is Medical Director of Evidence-Based Programs of the Senior Life Department of Medicine and Medical Director of the Healthy Living Center of Excellence in Boston. He is also a clinical instructor of medicine at Harvard Medical School. He served as Physician-in-Chief and CMO of Hebrews Senior Life in Boston, Massachusetts from 2004 to 2012. He helped to develop the strategic direction of Hebrews Senior Life medical groups in home and community-based services, long-term care, and post-acute care. We will call him Rob from this point. Dr. David A. Guggenheim earned his bachelor's degree from the University of Connecticut and an MA and a doctorate in psychology for clinical psychology from the American School of Professional Psychology in Washington, D.C. He began his career at CHC Incorporated, a statewide FQHC, Federally Qualified Health Center, in Connecticut, and served as Associate Chief Behavioral Health Officer. Dr. Guggenheim is trained as a coach in the Dartmouth Clinical Microsystem approach to PI and worked closely with research institutions to provide collaborative treatment for chronic pain and addiction. He led a team in the development of his organization's shared medical visits for patients living with diabetes and other chronic health conditions. He is also a Geiger-Gibson Capstone Fellowship graduate and regularly presents to healthcare teams about integrated mental health and primary care service delivery and the delivery of care to LGBTQ populations. In his recent role as Chief Mental Health Officer at Callan Lord in New York City, Dr. Guggenheim works to expand access to integrated LGBTQ sensitive and affirming integrated primary care and mental health services. From this point on, we will refer to Dr. Guggenheim as Dave. I'm going to turn it over now to Dave.
Thank you, Karen. So what is an SMA? Shared medical appointments, or SMAs, are an alternative to the standard individual outpatient medical appointment. They typically include an E&M visit with each patient, as well as an educational or counseling component done as a group. SMAs can be used for care and ongoing follow-up of a chronic or behavioral condition and would be an effective and efficient way to deliver diabetes self-management education, or DSME, in primary care. SMAs typically consist of staff-formed groups of about 10 to 12 patients who have common conditions such as type 2 diabetes, hypertension, depression, or COPD. Newer Medicare-covered services that may be appropriate to offer as SMAs include alcohol misuse counseling, smoking or tobacco cessation, cardiac risk reduction counseling, and intensive behavioral counseling for obesity. And we'll go into greater detail about some of those. So some of the benefits to patients. SMAs have been used for many years and are often used for chronic medical conditions. Many include motivational interviewing, and sometimes this is a part of a behavioral health component led by a social worker or psychologist. There is evidence of improvement in mental health outcomes as a result of group participation, not only for SMAs, but group therapy in general. This may be because group members get a chance, they get to interact with one another, they gain support from one another, and sort of network with people who are similar. And there's quite a bit of research supporting the use of SMAs in practice. For example, in one study, researchers used monthly 2-hour SMAs with a multidisciplinary team. The team included a nurse educator, dietitian, pharmacist, and a behavioral therapist. In the study, all participants had elevated A1C levels, and the control group's care was managed as usual by their PCP. The SMA patients had more of a reduction in A1C than the usual care group. They had lower hospitalization admission rates and reported more self-efficacy related to balancing food intake and glucose level. They were also better able to treat hypoglycemia and manage their blood glucose when they were ill. In another study, authors conducted a randomized controlled trial over 5 years and found that participants in the SMA group had an increase in knowledge of diabetes care versus a decrease in the control group. So they were more knowledgeable about care for their diabetes. The SMA group showed an increase in problem-solving abilities versus the control group. In the SMA group overall, the A1C was maintained, while in the control group, the A1C levels actually increased. On a quality of life measure, participants rated a higher quality of life in the SMA group after participation versus a decrease in the control group. So you can see here, these are many benefits to SMAs. In one last study that I'll discuss, in 2007, researchers also found that shared medical appointments foster more trust in a patient's physician and help physicians meeting ADA standards. So when we look at all the research that I've just discussed, we know that group visits are associated with decreased emergency department utilization, improved quality of life, improved self-efficacy, increased adherence, and increased knowledge.
Thank you, Dave, for explaining the benefits to the patient, and what I'll now take on is the benefits to the provider of doing SMAs. So the benefits to the provider are many. Think about the number of times a day or a week or a month you repeat a lot of the same recommendations or education. This can be greatly reduced when you group patients together. It actually gives you more flexibility in the schedule because you are seeing 10 to 12 patients at a time, possibly freeing up more time to dealing with individual cases that need more of your attention. It also allows you to spend more face-to-face time with patients in that group without increasing the time you spend in your practice setting. Much of the time, you already have the expertise needed within you and your medical staff, so no new hiring is needed. Further, during group visits allows you to reduce overhead costs, decreases patient wait times, and usually results in higher patient satisfaction rates. Now, I'd like to discuss other value propositions of SMAs to providers. You have them listed in front of you. The first I'll be talking about is patient activation. Studies have shown that SMAs enhance patient ownership for their own health and health behaviors. We'll be discussing the impact on health outcomes and cost a little later in the presentation. The second value proposition involves improving quality measures tied to incentive payments. When you are able to show improvement in key measures that you choose, such as blood pressure control or A1C control, this may factor into positive payment adjustments in the following year, given the new payment changes that are happening now involving MACRA and MIPS. Payment adjustments can be as high as 4% in the first year in 2019, where incentives are being paid out. If you don't plan to make improvements, your payments could actually go down by 4% just in that first year. Another value proposition of SMAs involves decreasing readmissions. By having improved clinical measures, this will likely mean fewer readmissions to your local hospital, and they will certainly be appreciative of that. And lastly, the value proposition of improving population health is an important one. SMAs are a great way for your practice to make substantial progress in improving the health status of your entire patient population. Given the fact that payments will be value-based in the coming years, as I just mentioned, it makes sense to start developing approaches that will improve the overall outcomes for your practice at this time. Benefits to your practice. SMAs have been used for many years, and they promote coordination among healthcare team members, including your allied health professionals. We knew that 86% of the nation's healthcare costs are related to chronic health conditions, and SMAs are useful in addressing these chronic conditions. Group visits have been shown to be effective at helping patients change their health-related behaviors. And an SMA can include more than the doctor charging for their time. For example, a psychologist or a licensed social worker could bill for the behavioral health component of the group visit if there is one. And as you can see listed here, and as Dave had mentioned, this applies to almost any chronic health condition. Other potential conditions for SMAs are listed below. Here are some of the common chronic conditions that likely permeate the patient panels in your practice and which shared medical appointments could be used for. These are involving both physical and mental conditions and include a number of behaviors that are associated with them. Insomnia, depression, anxiety, as well as cognitive impairment are some of these, but in addition, shared medical appointments can be used for, well, child visits, prenatal care, or really any common or costly chronic condition. I'm going to turn this over now to Dave.
Thanks, Rob. So on this slide, we have an example of a shared medical visit that I actually ran in practice. In this SMA, we identified about 35 patients who were eligible and ended up with about 20 to 25 patients coming to the session. Sessions were for 2 hours, though the provider, again, is only part of the first hour. The patients met with a nurse, a medical assistant, and were screened by a behavioral health provider for depression as needed based on what we prepared in our chart review. As patients arrive, the nutritionist begins their session with the patients and speaks about managing diabetes and healthy eating. This was followed by an information and discussion session with the medical provider. We also had a behavioral health provider, a social worker, who was able to use motivational interviewing techniques and SMART goal setting with the group. In some groups, we had a dental provider run part of the session discussing diabetes and oral hygiene. All groups are run interactively. Patients are not being lectured, but instead part of the program and able to speak with one another and their providers. Some groups are able to set shared goals, such as exercising twice per week. On the next slide, we see components and their value. In 2 hours, 10 to 12 patients participate in individual follow-up medical visits by their provider and also get an interactive group focused on lifestyle behavior change education by an educator, which might be a nurse, a dietitian, a social worker, or other allied health team member, depending on the condition and the issue that you're addressing. This allows for high-quality care and education in the same encounter, but the provider does not have to be present for the education component. Two distinct components in practice and for billing purposes.
So now we'll talk about the return on investment of an engaged patient, and in particular, avoidable hospitalizations. This graph shows the odds of hospital use after 1 year, stratified by patient activation level, which is measured by the validated patient activation measure developed by Judy Hibbard. The more activated a patient is to care for themselves, the less likely they are to show up at the hospital. Patients with the lowest activation scores at baseline had a 62% greater likelihood of having an avoidable hospitalization compared to the most activated group 1 year later, again after controlling for baseline demographics and chronic conditions. 2 years later, the difference between the least and most activated groups was 40%, while 3 years later, the difference was still 30%. So to be clear, those patients with the lowest activation scores often have poor health and quality outcomes as well as higher costs. In this study, there was also a return on investment of an engaged patient involving the development of new chronic diseases. This was a second finding which was perhaps even more intriguing. After controlling for baseline chronic conditions and demographic characteristics, patients at the lowest activation level at baseline were 25% more likely to develop a new chronic disease in the next calendar year compared to patients at the highest activation level. The same analysis, 2 years after baseline, showed a 31% difference between the lowest and highest activation groups. 3 years after baseline, the difference was still 21%.
Thanks, Rob. As Rob mentioned, patient activation and engagement pays off. Now I'm going to talk a bit about return on investment. This chart shows you how you would calculate the reimbursement for an SMA using E&M codes for each patient, and then the DSMT group code of G0109 for the educator, who is part of an accredited or recognized DSME program billing Medicare. These rates are based on the 2017 CMS fee schedule, but we took liberty to round so we have zeros on the end for example purposes. We assume you schedule about 12 to 14 patients, again that may vary, and end up with about 10 at the visit. The patients are there about 2 hours, but the physician or mid-level would be spending just 1 hour. The educator would use the other hour for DSMT or whichever other education or behavior program you are doing. The E&M visits billed by the physician or mid-level would be $99214 at roughly $100 per patient. The reimbursement for educating 10 patients would be $300 per hour, and for the medical visit for 10 patients about $1,000 per hour, for a grand total of $1,300 for 2 hours. If you want to take this collective payment back at the hourly rate, it's about $650 an hour. On the right side, we can see the total hourly payment rate of a physician doing traditional one-on-one visits, $300 per hour. Even if you do not have a billable DSMT program or you are having your staff teach on some other condition that is not billable, you still come out ahead by doing SMAs and billing only for the E&M visits, $1,000 per hour versus $300 per hour. Here's a recap of the bottom line based on the previous slide. Also, you may see improved patient activation, as Rob mentioned. You may see increased medication adherence, primary care utilization, increased patient satisfaction scores, and improved quality incentive payments in the following year. Here is a similar example, but with a behavioral health provider instead of an educator. So your E&M visits remain the same. Then you could have a licensed social worker, psychologist, or psychiatrist do a behavioral health intervention with the group and bill using 96153, which puts you at $200 per hour for 10 patients just for the behavioral health intervention. So your grand total is $1,200. Again, this is 10 times the payment per hour as sticking with one-on-one visits. So setup costs. Here's a chart to help you break down your setup costs. Basically, you want to record which staff are going to do what, how long that will take, and estimate your labor. Then, if you already have a room large enough, decide if there's any costs related to using that room for 2 hours every month or two. If you have to build on the room or rent the room, that would cost you a bit that you'd want to add on. Then you have the minimal costs of supplies and forms. You are probably already spending money on consent forms and some educational handouts for these patient one-on-ones, so you may not have any additional costs to figure in. If you are making the education more robust than it has previously been, you may have one-time costs to supply your educator with visuals, such as food models or a wounded foot model to discuss foot care for diabetes, for instance. In terms of time frame, the time frame is typically 2 hours and includes a private triage RN. Then the moderator opens the appointment with housekeeping items, sets the tone, the provider comes into the group, and possibly pulls patients out during their other parts to have one-on-one time. The educator comes in for behavior change education piece, then wrap up, action planning, and reminders for the next group visit. In Part 2 of this series, we will explain the planning and execution of SMAs in great detail.
Thanks, Dave. So now that we've demonstrated the value of doing group visits, let's talk a little bit more about the billing aspects. No additional CMS code exists to really denote these medical visits done in a group format. And so performing these services in groups does not really affect coding, billing, or reimbursement per patient. Any applicable E&M code may be used. Medicare has actually disseminated general policy statements in support of reimbursement of group medical visits, but there is a regional variation. Other insurers, especially commercial insurers, may have policies for reimbursement of group visits, so these programs could be done with commercial insurers if, in fact, they support these types of approaches. I think what's important, however, is that you always should check with your Medicare Administrative Contractor, or MAC, to make sure you and they are interpreting the billing the same way. And if they know that you are doing group visits, it might prevent them from doing an audit when they see multiple E&M and lifestyle codes being billed that same day. So common billing practices, let's review that. It's really important that you document clearly with two distinct parts. There needs to be an E&M code, and usually 99213 or 99214 are the ones that we use. And it's really important to emphasize the medical management component. There is a short list of education services that can be billed for the education part. Diabetes self-management, teaching by an accredited or recognized diabetes self-management education program, medical nutrition therapy, or MNT, by a registered dietitian, or an intensive behavioral treatment, or IBT, for cardiovascular disease. Check with your Medicare Administrative Contractor to see if they will accept claims for the intensive behavioral therapy for cardiovascular disease done as a group. The CMS policy is not 100% clear about this point involving groups with cardiovascular disease. We've included the reference that describes the IBT for cardiovascular disease policy at the end of this presentation. So there are medical and behavioral codes that need to be included. We talked about the EMN level based on complexity. Again, 99213 and 214 were the ones that I mentioned, but you could use any of the E&M codes from 99212, especially if it's a very short visit and you don't do much medical management, up to something very complex as a 99215. If you're a psychologist, psychiatrist, social worker, or psychiatric nurse practitioner, you may be able to use the CPT code 96153. So let's talk about more of the lifestyle and education group billing. The procedure code that should be billed by an educator or the facility in which SMAs are furnished, such as a provider's practice or hospital clinic, will be discussed at this point. It's really important, for example, if you're billing on behalf of the educator, that the DSMT can be billed by a registered dietitian or a podiatrist or a psychologist, in addition to the traditional medical practitioners. For example, a clinical nurse specialist that's doing education can also bill for the lifestyle education component. Be sure, however, that the MPI number of the educator or the MPI number of the lifestyle behavior change program is different than the MPI number of the medical provider, such as the mid-level or physician doing the E&M visit on the claim. So let's talk now about the lifestyle education codes and rates. And as you see on the slide, we have the different codes on the first column and the time that these codes require for the unit to be billed, as well as the service and then the reimbursement. The highlighted rows are the group codes for DSMT, MNT, and IBT for cardiovascular disease that you could potentially use as an education component of the shared medical appointment. Note that you would never use DSMT and MNT on the same day, as those are not billable per Medicare. You have to use one or the other. Also notice if you're going to use these in your own hourly rate calculations, some of these are 30-minute codes and some are 15-minute codes. So you would need to multiply these dollar values up to determine the hourly rate for reimbursement. These dollar values that you see in the last column in 2017 are from the national payment amount on the CMS fee schedule for that year. So your local value might vary slightly.
Thank you, Rob and Dave. This wraps up Shared Medical Appointments Part 1, Value and Return on Investment. Check out the references on the next slide if you want to read more. If you have a burning question for Dr. Guggenheim or Dr. Schreiber, they've graciously made their emails available here. On the references slide, note the Eisenstadt reference from 2012 is an online book you can use to further educate and prepare yourself for implementing shared medical appointments. Thank you so much for participating in this bite-sized learning. We hope you found Shared Medical Appointments Part 1 useful to your practice. We value your feedback, so please take a few moments to click on the SurveyMonkey link in the slides that are accompanying this recording and let us know what you think. If you have a question or comment that you'd like to email us directly, please use this email link here, quinnncc@area-d.hcqis.org. And don't forget, Shared Medical Appointments Part 2, Operationalizing.